Okay, so again, I apologize for not being able to get to this in class, but we're going to briefly talk about personality disorders. So, with personality disorders, there's a couple things that you have to understand that make them different from other disorders, other psychiatric disorders that we've talked about up to this point. One of the biggest differences is the difference between ego syntonic and ego dystonic. So we talked about this briefly earlier in the semester, but remember, one of the criteria of a psychiatric disorder is that it is distressing to the individual. It's causing some type of impairment in their functioning, it's causing some type of psychological distress to them. Personality disorders are kind of unique in that they usually uh, don't typically cause distress with the individual. So the actual symptoms that they're experiencing seem pretty consistent with their sense of self. So, for example, an individual who is depressed or is suffering from major depressive disorder, that depression feels different from their their typical experience, from their idea of themselves. So it is ego dystonic. It's not matching up with their sense of self. So ego here means self, dystonic means not matching up with or not being in sync with. Personality disorders, again, are ego symptomic, typically, those symptoms that we'll talk about, meaning that this isn't a big change for the patient. It is kind of what they typically experience, what they expect to have happen. Another big difference is because it is this ego syntonic thing, because it's not outside of the norm for these patients, is that personality disorders are kind of defined by this distorted, pervasive, inflexible pattern of thinking. Again, it is not just symptoms that they're experiencing for a small period of time or for 6 months. It is something that is, again, kind of their baseline. It's problematic emotional responses. It creates interpersonal difficulties, and it's this pervasive long-term pattern of thinking. Now, for personality disorders, the onset is always going to be in late adolescence or early adulthood. You have to be 18 to be diagnosed with a personality disorder. That is one of the criteria for every personality disorder, is that the patient be at least 18 years old. So the way that we used to talk about personality disorders is we used to have them in clusters. So we would have cluster A, cluster B, and cluster C. I find that it's more helpful to talk about these personality disorders kind of, instead of as a monolith of personality disorders, to talk about them more in relation to the other symptoms that we're seeing. So in cluster A, for example, this is the odd or eccentric cluster. So this would be personality disorders like schizotypal personality disorder, schizoid personality disorder, and paranoid personality disorder. So we actually talked about these already in the semester when we talked about disorders that fall within the schizophrenic spectrum. And I think that, based on the symptoms, those fit a lot better into that category than they kind of match up with these other personality disorders. Similarly, with cluster C, we'll talk about the cluster C personality disorders, the anxious and fearful personality disorders, when we talk about anxiety in a couple of weeks. So the cluster C personality disorders are going to be the obsessive compulsive personality disorder, avoidant personality disorder, and dependent personality disorder. Again, we'll talk about these in a couple of weeks. So really the main thing that you need to worry about for this upcoming exam, and kind of for what you're responsible for this time, is the cluster B personality disorders. So these are characterized by being dramatic, emotional, and erratic. Some of the kind of key criteria for this cluster is they have poor impulse control, they have difficulty empathizing with others, they tend to exhibit manipulative behavior. Again, they're very characterized by those extreme, exaggerated emotional responses, and they tend to have poor boundaries and respect for limits. So, in the class today, we already talked about borderline personality disorder, and this is kind of the most common personality disorder that falls in the cluster B. Since we already spoke about this, I won't spend too much time on this. This, again, is just a reiteration. This slide is a reiteration of the symptoms that we already spoke about earlier in class. The other personality disorders that fall within cluster B are antisocial personality disorder. Antisocial personality disorder is characterized by a pervasive pattern of disregard for and violation of the rights of others. So usually what you're going to see is people who are very deceitful, very manipulative. Sometimes they're characterized as being amoral or callous. Usually they are very egocentric, meaning that they are the most important person in the world. They have some kind of special innate power. They have a sense of superiority in relation to others. And because of this, they have a hard time empathizing with others. Usually they have a very difficult time showing remorse or guilt. And there's arguments about whether or not they have a conscience. So what we see, kind of the result of this, is the tendency to display violence, to display violence, to be irritable, to be impulsive, to be aggressive towards others, to not take on responsibility, for things like failures. And with this personality disorder, some older terms that were associated with this are things like psychopath or sociopath. Those are older terms that aren't super useful. There's no real kind of unifying definition of what is a psychopath versus what is a sociopath. So really kind of the understanding is that they all fit into this category of antisocial personality disorder, which even the name antisocial personality disorder can kind of sound like a misnomer. It's not necessarily that these individuals are antisocial, like, oh, I'm feeling antisocial today, I don't want to be around people. It's more antisocial in the idea of kind of disobeying society's rules. So we have kind of the societal expectation that we're going to not manipulate others, that we're going to not solely look out for ourselves, that we have kind of a group mentality, a social mentality. So when we're talking about antisocial personality disorder, it's specifically looking at kind of breaking those societal norms of kind of what is expected. Now, even though these terms are antisocial personality disorder and the older terms of like psychopathy and sociopathy, even though those terms are really heavily associated with things like serial killers and kind of sensational depictions of antisocial personality disorder, it's important to realize that most individuals with antisocial personality disorder are non-violent. Antisocial personality disorder affects about an estimated 3% of the population. There is a theory that we see more individuals with antisocial personality disorder in politics or in as CEOs of companies, partly because of that idea for seeking out power, for kind of having that manipulative or egocentric behavior. The two examples we have here in the slide are Ted Bundy, a very notorious serial killer, and then also Steve Jobs, who people have theorized might have suffered from antisocial personality disorder. So again, it's important to realize, like I said before, most of these patients are not violent. But they have that difficulty kind of empathizing with others, and this might lead to things like violence. So some related disorders, like I mentioned earlier, to have a diagnosis of a personality disorder, you have to be at least 18 years old. Well, we have kind of a corresponding diagnosis almost with conduct disorder. So conduct disorder, to receive this diagnosis, you have to be under the age of 18. With symptoms beginning before the age of 15 and lasting at least 6 months. So you have to have these symptoms again, before the age of 15, and you can't be diagnosed with this after the age 18. So we see some of the kind of similar behaviors, just kind of in a different developmental level that we would with antisocial personality disorder. So we see things like aggression. This can look like cruelty to animals, bullying, causing physical harm to others. It can look like sexual misconduct, deliberate destruction of property, so kind of a disregard for others, for other individuals' autonomy, and also for others' property. Deceitfulness or theft, so again, kind of displaying that amorality, that callousness, that egocentric kind of idea of, this will, the rules don't apply to me. I'm above the rules. I can make my own rules, kind of thing. Now, this conduct disorder is not technically a personality disorder, but again, it does seem like it might be a precursor to antisocial personality disorder. And depending on what study you look at, anywhere from about 40% of individuals to 70% of individuals diagnosed with conduct disorder later go on to meet the criteria for antisocial personality disorder. So there does seem to be some correlation here. Another disorder that we just kind of need to tease out and make sure that we understand kind of what the difference is oppositional defiant disorder. So this is also a disorder that is primarily seen in children, although some adults can be diagnosed with this. So this is a pattern of irritability and anger in response to limits or barriers. So remember, one of the kind of key characteristics of the cluster B personality disorders is that disregard for limits, or that kind of violation of barriers or of the rights of others. So what we see in oppositional defiant disorder is we see really short temper, emotional lability. So remember, again, that's those mood swings. We see individuals deliberately disobeying rules, being argumentative, having defiant behaviors, being vindictive, kind of going out and seeking out vengeance. Now, the real difference here is that with oppositional defiant disorder, you usually don't have incidents of violence or aggression. There's not really incidents of property destruction or of theft. With oppositional defiant disorder, this is usually more emotional kind of dysregulation. So the emotional lability is one of the really key factors here. But then also the idea that they will argue with someone, but then that argument doesn't usually kind of escalate to violence or to kind of a physical aggression. So again, just kind of understanding the difference here of kind of what oppositional defiant disorder is versus antisocial personality disorder or conduct disorder, because a lot of the terms here are kind of not the common way that we use these terms. So another diagnosis that falls within the cluster B personality disorders is histrionic personality disorder. So this is characterized primarily by excessive emotionality and attention seeking. This sounds a lot like borderline personality disorder or like antisocial personality disorder, and partly that's because they are very, very closely related. The kind of key differences here with histrionic personality disorder is usually the individual still has a pretty good sense of who they are as an individual, whereas in borderline personality disorder, individuals will have those dissociative emotions and kind of a lack of sense of self, feeling really empty inside. Whereas individuals with histrionic personality disorder tend to have a really good idea of who they are as an individual, but they then use kind of self-dramatization or big theatrics or exaggerated expressions or even aggressiveness to get their needs met. Other ways that this can look is things like inappropriate sexually seductive behavior or provocative behavior. There can be rapid emotion shifting, kind of this emotional lability, but again, kind of their sense of self is usually intact with this. So usually they're using a lot of emotions to manipulate others, and those emotions can be feeling bad for them. They can also be a desire to have sex with them. Histrionic personality disorder, similar again to borderline personality disorder, is predominantly uh, diagnosed in women, and even the name is kind of problematic in that histrionic personality disorder. So remember, histrionic has the same roots as hysteria. This idea that the womb would detach itself from where it usually sits and float around to different areas of the body and end up having all of these effects like rapid emotion shifting or chest pains if the uterus is sitting in the chest and things like that. So really, like, this name has some problematic history. The fact that it's diagnosed primarily in women is also kind of problematic. So there's discussion about whether this is kind of its own unique disorder or whether this is maybe just a different kind of manifestation of antisocial personality disorder, because both antisocial personality disorder and histrionic personality disorder, they're both using manipulation to get others to do what they want, to kind of disobey rules or norms. Just kind of the way that they do that manipulation looks a little bit different. So in histrionic personality disorder, it's usually sexuality and emotions that they're using, whereas in antisocial personality disorder, it's usually aggressiveness, a dominance over another individual that you're using as manipulation. So some of the discussion is this a unique disorder, or is this maybe just a female presentation of antisocial personality disorder? The last disorder that falls into this cluster B personality disorder spectrum is narcissistic personality disorder. And this is characterized by individuals having a grandiose, arrogant, and haughty attitude or behavior. What makes this different, so like you have this kind of idea of having difficulty empathizing with others or relating to others, this idea that you are better than everyone else, and you will use deceitfulness and exaggeration to make yourself better than everyone else, or to make yourself seem more important than everyone else. Now, the key difference here between this and antisocial personality disorder is the need for admiration. So this need is not something that we see in antisocial personality disorder. Individuals with antisocial personality disorder don't really care what you think about them as long as their needs are getting met, as long as they're getting what they want, as long as they are, as long as their goals are achieved. They don't really care what other people think about them. Individuals with narcissistic personality disorder, on the other hand, need people to think that they're great. They need people to shower them with praise. But again, similar to some of the other disorders that we've talked about, like borderline personality disorder, that admiration is never enough. So it's kind of trying to fill up a bucket that has a hole in it. No matter how much water you put into that bucket, that hole is going to be leaking out just as fast as you're filling it up. So you can be pouring admiration and emotion into these individuals all of the time, and it's still not going to be enough. It's not going to feel like it's enough for them. And this need for admiration can compromise other things. So they will go out of their way to get this need met, to make other people, to manipulate other people into praising them, even when it's not warranted. And they will get frustrated really quickly and can become aggressive with people if they aren't receiving the praise that they feel like they need. So what are some of the interventions that are going to be helpful for individuals with personality disorders? And again, a lot of this is going to be focusing really strictly on cluster B personality disorders. Well, one of the most important things is being consistent and setting limits or boundaries. Remember, one of the kind of key characteristics of these disorders is that they have a difficult time following rules, staying within specific boundaries, of not becoming too intimate with others, whether that's sexual intimacy or emotional intimacy, manipulating others to get what they want. So it is really, really important that we are very consistent with this population and following the rules, and that we set really clear limits for what is expected, and we follow those limits and those consequences. One of the other things that we're going to do as part of maintaining that consistency is demonstrating patience and maintaining stability for the patient. Just like we talked about with borderline personality disorder, these patients can appear to be very frustrating, and it can be very difficult to work with these patients. It requires a lot of patience to be able to kind of let them have their emotional responses, to let them express what they need to, and yet still stay consistent with the rules and still can stay consistent with the consequences. You also need to make sure that you're assessing for self-harm and for suicidality. Again, this is most especially true with individuals with borderline personality disorder, but it can relate to any of the disorders that fall into this cluster B. We also want to help teach patients strategies for managing impulsive behavior, strong emotions, and erratic behaviors. Again, coming back up to one of the key characteristics of cluster B personality disorders, we see really strong emotional responses, a propensity for impulsivity, and kind of what appear to be erratic behaviors. So what we look at is kind of creating strategies for how to handle those behaviors. Earlier we talked about distress tolerance for individuals with borderline personality disorder. Kind of similarly, we're teaching maybe distress tolerance or mindfulness or kind of managing emotions in a healthier way for these other individuals. Remember, again, this isn't about controlling emotions or getting rid of emotions. It's about managing those emotions that come up, managing those impulsive feelings when they come up, managing those erratic behaviors when we have those impulses. Then we also want to challenge dichotomous thinking. Again, this is most prominent in individuals with borderline personality disorder, but it is kind of a key factor in a lot of these cluster B personality disorders that we see this black or white, all or nothing thinking. So we want to challenge that thinking and challenge them to think of some other ways that this might, some other possible explanations. So maybe it's not that the nurse is out to get you. Maybe it's that the nurse understands that there's rules that need to be followed for the unit. And we can explain those to patients. We can talk through why that is, so they can kind of see that this isn't just us being vindictive against them, but it's us having rules for a very specific reason. Okay, let's look at a couple of questions real quick that we didn't get to in class. So these are the multiple choice questions. So what I want you to do is just write down your answer, and then we'll kind of talk about what answer might be appropriate or kind of how to approach questions like this. So question 2, Lena is a patient at your OBGYN clinic. During a reproductive system assessment, Lena mentions that she had recently been stopped by the police and got her second DUI, but minimizes the consequences of this legal issue. What nursing intervention or action would be best to take first in this situation? A, use the CAGE questionnaire to assess Lena's alcohol use. B, notify the physician and the interdisciplinary healthcare team. C, refocus Lena to the assessment questions related to her reproductive system. D, document these comments in Lena's EMR, her electronic medical record. E, use the CWA questionnaire to assess Lena's alcohol dependence. So the correct answer here is going to be A. Use the CAGE questionnaire to assess Lena's alcohol use. Now, to get to this correct answer, we need to look at, again, what is always come back to what is the question asking? What information is it specifically looking for? So we can look at the stem of the question. We know that this is a reproductive systems assessment. We know that Lena has mentioned this DUI just kind of casually. We know that this is her second DUI, so this is repeated behavior. We also know that she's minimizing the legal consequences of this. So if we think back to kind of what is the criteria for a substance use disorder, one of the criteria is that it's long-term excessive use, it causes some kind of issue or some kind of dysfunction in the person's life, and they continue to do it despite negative consequences. So we have a couple of red flags already showing up in Lena's assessment that we can look at and say, okay, yeah, I think that it would be appropriate to assess her substance use. So if we're looking at assessment as kind of, the one of the main things that we want to do, we need to look a little bit further into the question. What nursing intervention or action would be the best to take first? So it's asking us not just to take the action for this, but to prioritize action. So what is the first thing that we want to do in this situation? Well, we want to use the CAGE questionnaire to assess Lena's alcohol use. So the CAGE questionnaire, remember, is looking at it's 4 specific questions that ask that help us get at is this use becoming problematic? So we're asking about, has she ever tried to cut down her usage? Has she ever been annoyed when other people criticize her alcohol usage? Has she ever felt guilty for drinking too much? And has she ever needed an eye opener in the morning, some alcohol in the morning to kind of calm her nerves after a long night of drinking? Now, what the CAGE questionnaire helps us get at is if there's a yes to one or more of those questions, that indicates a high likelihood of alcohol abuse or kind of problematic alcohol use. So that would be the best option here. Now, if we look at options B and D, notify the physician and the interdisciplinary healthcare team, and D, document the comments in Lena's EMR, her electronic medical record. Those are absolutely things that the nurse is going to want to do. However, they're not the first thing that you want to do. So remember, this is looking at prioritizing time. So because we have Lena right there with us, we want to continue our assessment of this potential problem. Also remember that the CWA is looking specifically at withdrawal symptoms from alcohol. So that wouldn't be an assessment that we would be doing here in the office. We need to see, does she have a problem, or is she engaging in riskier drinking patterns? Okay, question 3. Which nursing action would the nurse do first when working with an individual with borderline personality disorder? A, set limits. B, determine boundaries. C, assess for self-harm. Or D, assess for relationship systems. So the correct answer here is going to be C, assess for self-harm. So we need to look again at the question. So the question is asking us, what is the first thing that we would want to do? So we know that individuals with borderline personality disorder have a much higher rate of engaging in non-suicidal self-injury or peri-suicidal behaviors or gestures. So assessing for self-harm is going to be the most important thing. Remember, again, safety is always our first concern. We always want to make sure that we are keeping the patient alive. Everything after that is going to be secondary. So whether that safety concern is maintaining their airway, stopping bleeding, or assessing for potential suicide, we always want to make sure we are keeping the patient alive is the very first thing that we want to worry about. All of the other things, again, are things that we want to do with patients who are suffering from borderline personality disorder. We want to set really strong limits. We want to determine boundaries with them. We want to assess their relationship systems and their social support networks. But the very first thing that we want to do, the most important thing that we need to do, is we need to make sure that they are safe. All right, thank you so much, everyone, for checking this out. If you have any questions, please feel free to message me and let me know. I apologize again that we couldn't get through all of this in class. Hopefully this was helpful, and good luck to everyone on the exam. If you have questions beforehand, please let me know. Have a good day. Bye.